Good evening, everyone. My name is Jay Feinberg, and I'm Gift of Life's founder and CEO. It is my great pleasure to welcome you to Gift of Life's Massachusetts Town Hall, addressing healthcare disparities in our communities. I'd like to thank our organizing partner, the NAACP, and our sponsors, Morgan Stanley, Fidelity Investments, the McKesson Foundation, and Rubius Therapeutics for their tremendous support. And very special thanks to my friends at the Dana-Farber Cancer Institute, especially my good friend, Dr. Joe Anton, and Blue Cross Blue Shield of Massachusetts for their long-standing friendship. Today's topic couldn't be more timely or important. We have watched as COVID-19 has spread throughout the United States, leaving a trail of human destruction in its wake. And we have been reminded of the inequities that permeate healthcare, resulting in unequal outcomes for people of color. These disparities extend far beyond our mission to provide a cure for those battling diseases like blood cancer, immunodeficiencies, and sickle cell. But as part of our mission to create equal healthcare outcomes for everyone, we are compelled to take action, addressing not only this, but the larger issue that the pandemic has further exposed. My personal story begins in the early 1990s when I was diagnosed with leukemia. Naturally, I was devastated, but relieved to learn that a bone marrow transplant could save my life. First, though, I would need to find a matching bone marrow donor. It wasn't until I met with a transplant physician in New York that I was told that I would never find a match because of my Jewish genetic heritage. You see, I had no idea that tissue type is inherited like the color of our eyes or our hair. So a patient's best chance of finding a genetic match lies with people of similar race and ethnicity. Unfortunately, the donor registry was not ethnically and racially diverse, likening the search to looking for a needle in a haystack. Thankfully, with a lot of hard work and a 4 year high profile grassroots campaign, I found my match. Now it's my life's mission to pay it forward. Every patient deserves an equal opportunity to benefit from the treatment that can save their life. The registry must, absolutely must, be representative of people of all backgrounds. To help give voice to this message and to encourage others to join in the fight against blood diseases, Gift of Life has launched a new short film in collaboration with rapper and lyricist Terrell Trizzy Miles, with creative support from the Lucy Collective and The Mill. And now allow me to introduce Blood is Thicker.
So Terrell, what made you want to write this, bro?
Because blood is thicker than water, like fathers.
Mothers, sons, and daughters. But what if I told you the blood relation can go farther than the people you know? You have the power to save a life with a simple swab of the cheek. That's all you need to make someone else's life complete. For those like me, or from a different creed, no matter what you look like, there's someone out there who you can be. A hero to, a vessel of new life. Someone who can bring them light when the road seems weak. For those who seek bone marrow or stem cells, through this one gesture, they will be allowed to prevail and tell the tale of how one small act managed to break the scale, and their life was allowed to once again set sail to heights unknown, to love once more. The gift of life, from my family to yours.
Absolutely incredible. Terrell, if you're watching, you are just so incredibly talented. The film you just saw, Blood is Thicker, is one of the initiatives we've put in place to educate communities on these very important issues. This town hall is another. And so, in partnership with the NAACP and Dynamic Changemakers, we are pleased to have you join us for this of one of many meaningful conversations about ensuring that Black, Indigenous people of color have safe, effective, and full access to healthcare and life-saving treatments. Now, it is my great pleasure to welcome tonight's moderator, Angela Clark, Diversity and Inclusion Leader at Fidelity Investments.
Thank you, Jay, and thank you so much for sharing the video. Good evening, everyone. I am excited and honored to be here with all of you this evening. My name is Angela Clark, and my pronouns are she, her, and hers. And on behalf of the Gift of Life Marrow Registry, we are excited together today to discuss the pressing issues surrounding health disparities and how we can all play a role in the solutions that affect lasting impact. The coronavirus pandemic and recent racial turmoil have brought racial healthcare inequality to the forefront of the national news and to everyone's awareness. The United States now accounts for more than 10 million COVID cases, and the death toll from the coronavirus has topped 239,000 to date, and that number continues to rise. Blacks and Latinos and Indigenous people all across this country and in every age group, including young people, have been disproportionately affected by the coronavirus. They are more likely to be diagnosed with the virus, more likely to be hospitalized because of the virus, and as a result, more likely to die from the virus. The numbers and the data points highlight the underlying and long-standing healthcare inequalities that have existed in our country, particularly in Black and Brown communities. These enduring health disparities have been fueled by decades of discrimination, mistrust of the healthcare system, unequal treatment, unequal opportunity for the economic, physical, and emotional health, and other issues that limit access to quality healthcare. And as a result, the health and wellness of people in underrepresented communities is often shaped by a deadly cycle of chronic disease and loss of life. A cycle that continues through generations, a cycle that devastates families and communities. These challenges remind us that barriers to health are interconnected, and the problem is bigger than any one disease, state, or chronic health condition. But here's the biggest challenge. Many people believe that they are unable to take action because the solutions often overwhelm instead of inspire. As you've heard from Jay, changing health outcomes is possible. Through action, Jay was able to turn a moment of crisis into one of transformation. You'll hear from more people shortly who agree and are working to overcome some of these healthcare disparities. We will explore how advocacy, partnerships, and youth-led efforts can serve as a powerful catalyst toward building and sustaining healthy and equitable communities throughout the discussion with our esteemed panelists. We have Dr. Catherine Dallow, a physician who serves as Vice President of the Clinical Programs and Strategy at Blue Cross Blue Shield of Massachusetts. Dr. Anton, Chair in Hematology and Professor of Medicine at the Dana-Farber Cancer Institute. And Dr. Ken Duckworth, who is the Chief Medical Officer at National Alliance on Mental Illness. And last but certainly not least, my new friend, Kamaya Parkin, who as President of the University of Massachusetts Boston NAACP chapter is working hard with the youth and the college division of the NAACP across this country in support of the program. Not only are youth proving to be catalysts and prolific communicators in social movements, but we believe their movement is key in creating healthier communities. We invite you to submit your questions in the chat at the bottom of your screen for a brief Q&A with our program experts at the end of the program. Okay, with that said, without further ado, let's get started. So let me welcome one more time our panels, Dr. Catherine Dallow, Dr. Joseph Anton, and Dr. Ken Duckworth. Welcome.
Thank you.
Yes, excited to be here. Okay, Dr. Dallow, I'm gonna have you kick us off. From your perspective, how has the COVID-19 pandemic served as a tipping point for disparities, specifically in underrepresented communities and communities of color?
Well, Angela, first, thanks to you and Jay. It's a pleasure to be here to talk about this extremely important topic. COVID has taken a disproportionate toll on Black, Hispanic, and Indigenous communities, as you say, spotlighting truly the ugly fact that racism pervades our healthcare system, even in more ways than we ever knew. just as racism afflicts nearly all aspects of our society. The causes of health disparities and equity are deep and include such social determinants of health as poverty, housing, education, nutrition, and racial bias. At Blue Cross, we view racism as a public health emergency and healthcare as a racial and social justice issue.
Thank you, Dr. Dallow. At the beginning, Jay mentioned that the disparity in the ability for Black people to find bone marrow or stem cell matches. Can you shed a little bit more light about the overall disparities, specifically in cancer?
Sure. So racial and ethnic disparities in cancer care have been recognized for decades. We know there's lack of adequate insurance that's disproportionate in communities of color, lower rates of screening for cancers, delayed follow-up after abnormal screening test results, diagnosis at a more advanced stage of disease related to all of those prior statistics, and treatment schedule disruptions are all more prevalent in communities of color. And those in the oncologic community know staying on schedule with treatments for oncologic care is critically important to the success of any regimen or treatment. Many basic socioeconomic issues that have been compounded by systemic racism in our country, such as lack of access to transportation, fresh food, pharmacies, access to child care or elder care services so that someone can seek care for themselves, and also sick time benefits that many of us take for granted through our places of employment. Those are not available to a lot of people, and especially disproportionately to communities of color. And they all stack the deck against identification, treatment, and recovery in oncologic care. There's also fundamental issue with trust in the healthcare system. That is lacking in these exact communities, fueled partially by historical events such as the Tuskegee syphilis experiment and the Henrietta Lacks legacy. Those are just two of the most prominently publicized and used, but the examples are numerous. Trust is fundamental to the patient care continuum, and especially so in a therapeutic relationship between a patient and a provider that lasts months in oncology at a minimum, and more often years, if not the life of the individual.
Okay, so then you probably know my next question. How has the Blue Cross Blue Shield of Massachusetts shifted to respond specifically to some of these healthcare disparities that we're seeing?
So we really have taken a hard look internally. We have a strong and proud foundation of commitment to diversity and inclusion over many, many years. And that has been foundational to us. It's part of our mission. But we've begun to think more boldly about how we might accelerate progress toward a better and more equitable future, both internally and externally. We know we have to do much more. To be a leader, we intend to be the leader in addressing injustice and championing equality within our company, our membership, and our state. We this year made a $1 million grant to the new Commonwealth Racial Equity and Social Justice Fund, and we'll be making other grants specifically aimed at promoting organizations focused on racial justice. As part of this multifaceted approach, we've planned to gather new data from our members. Obviously, that takes cooperation and collaboration between us, our members, our employers, our providers, and really linking arms to work with healthcare providers to understand patterns of inequities, whether that be in cancer care or other areas, and introduce targeted incentives and enhanced support to reduce disparities. We're also evolving our own company's current diversity and inclusion governance structure to include health equity issues. It is now our diversity, equity, and inclusion governance structure. And we're publishing company-wide new scorecard that measures progress against other best-in-class companies to ensure accountability and, above all, transparency. We also know best-in-class isn't good enough. Best-in-class today is not where we need to be. We need to have a better bar. We're educating our employees on the impact of race and socioeconomic factors on Blue Cross members, in addition to the general public at large, and effectively using this information in day-to-day interactions, both internally and externally. We're also leveraging our public journalism website coverage to drive education and awareness internally and externally about racial equity in healthcare. And honestly, part of my role in this panel and other venues where we've had invitations is paramount. We want to be out there helping have these discussions and addressing these issues head on.
That's amazing. Thank you. I keep thinking about the word trust in my mind. Well, thank you. Okay, Dr. Anton, the next question is for you, sir. As the head of the stem cell transplant program at Dana-Farber, you have been fighting to change the odds that many people face in their journey to find a marrow match. Can you talk to us briefly about sickle cell disease and talk about the main barriers to successful transplants today?
Right. So sickle cell disease, of course, is a horrible illness. It's manifest as extreme pain crises where people have really very significant disruptions of their life and are often in chronic pain. This is due to an abnormality in hemoglobin that's genetically determined. It occurs in primarily people from Africa, but other people in the Mediterranean and Southeast Asia, where it evolved as a partial protection against malaria. Because it's prevalent in the African American community, and transplantation is really the only curative therapy for this, our mission is to provide as many allogeneic transplants, these are transplants using a healthy donor, so that we can replace the underlying abnormal blood cell production with healthy blood cell production that doesn't sickle. The problem is the registries are disproportionately Caucasian. And there are a number of reasons for that. One is that if you think about who joins a registry, it's primarily people who feel safe, people who have food on the table, people who have money, people who can take time off from work. And that is not the description of large parts of the African American community in the United States. We're also highly dependent on individual registries in foreign countries. So for instance, if I'm looking for a donor for someone who is Japanese in the United States, I'm more likely to find one in the Japanese registry than in the US registry or the English registry or the German registry. And unfortunately, most of the African countries really have not prioritized the development of registries for a variety of reasons. To some extent, it's because they have to direct their funds to initiatives that are more basic than purely the treatment of patients with sickle cell disease. And so we can't take advantage of those countries to increase the donor pool. So what are our strategies? Well, there are a number. One is that we can recruit people in the United States to the extent that that's possible to increase the number of people of color in the registry. One of our very prominent research goals is to make transplantation successful in patients who are not fully matched. That is, if you require a donor who is fully histocompatible, it's going to be difficult in using the unrelated donor register. As Jay pointed out in his introduction, 25 or 30% of African Americans in the United States will have a compatible donor, whereas that's compared to about 70% of people of Western European origin. So one strategy is to make transplantation safe and effective for those people who don't have a full match, so we can do partial mismatches. And we have a great deal of money and grant support and time and effort directed towards that right now. And then the last is to genetically engineer the bone marrow so that it doesn't sickle anymore. And we're doing this in conjunction with our colleagues at Children's Hospital in Boston, where bone marrow can be taken from the patient, genetically modified so that it doesn't sickle, and then given back to the patient. In that case, you don't need to have a donor. But we also depend on organizations like Gift of Life and Be the Match to have recruitment activities in the African American community to increase the availability of donors, since that ultimately is the way we need to go.
Dr. Anton, thank you. Before I move on to Dr. Duckworth to talk more about mental health specifically, you mentioned the allogeneic. transplants. And I am just starting to familiarize myself with some of the terminology. So I would ask for all those folks out there who are just starting to learn more about this and have looked on the Gift of Life website, can you just quickly explain what that means?
Absolutely. Uh, when we use stem cells or bone marrow cells from someone other than an identical twin, it's called allogeneic. If we use stem cells from your own bone marrow, it's called autologous, and from anybody else, it would be allogeneic. So if we do a bone marrow transplantation from a sister to a brother, that's allogeneic. From an unrelated donor to our patient, it's allogeneic.
Perfect. Thank you. Dr. Duckworth, how are you?
I'm fine. How are you doing?
I'm doing well. Much like with cancer and the coronavirus, communities of colors are disproportionately weighed down by the heavy burdens of stress, as we can imagine. How can we continue to fight the stigma in communities of color and encourage people to seek mental health help?
Well, thank you, Angela. Again, a long-standing problem in our society due to systemic racism and a lack of access to care, but also broken trust. The mental health field misdiagnosed people of color for many years, misinterpreting some of their experiences as paranoia and overdiagnosing psychosis. So the CDC released a large study at the end of June, and it looked at certain populations who were experiencing depression, anxiety, and trauma. They were using well-established metrics, an online interview, but quite compelling. And what we found is subpopulations, Latino populations, the Latinx population, the African-American population, young adults, essential workers, and caregivers all had very high numbers of reports of anxiety, depression, or trauma. And I think that if you start to look at these populations, you have to think about, how can we make the service system and the culture more acceptable for people to seek help? Because I do think we've hit a tipping point in the COVID-19 pandemic where so many people are having mental health vulnerabilities. I think this calls into special relief the needs we need, the needs we have to attend to populations that are impacted in greater numbers, including African Americans and the Latinx population.
That's perfect. Thank you. How can someone help a friend or other loved ones who might need mental health support?
So Angela, a lot of this is very specific. It depends upon your relationship with them, right? Many people, let's just take seasonal affective disorder. Here in Boston, it gets dark early. And there are some things that are quite predictable. It's possible that you can learn that every winter you're going to have trouble with depression. And there is a light box therapy that works with that. There is this concept of motivational interviewing, which is I may be able to see things in my Venn diagram, the other person sees things in their Venn diagram, and you try to look at what's in the middle. So for example, you might love someone who you are concerned is depressed, and they don't want to think that way for many reasons. And they do acknowledge that they're having difficulty with sleep. So as a clinician, you would focus on sleep as, let's problem solve the thing we can both see. And I think that's one way to start. This grew out of the addiction literature, this whole idea of motivational interviewing, that you don't have to lead with, I think you have this mental health condition, which carries shame and prejudice for a lot of people. I encourage people to, lead with love and to stick with things that you can both see.
Lead with love. I love that. Thank you. Let me now bring Kamaya Parkin back into the conversation. Hi, Kamaya.
Hi, Angela. Thank you for having me. How are you?
I'm doing well. Thank you for joining. So Kamaya, today's conversation is part of, as you know, a series of town hall conversations taking place virtually on college campuses nationwide. From the NAACP's perspective, what can young people specifically young people, college students, college age, do to make a difference?
Yeah, of course. I think that's a really great question. And young people, particularly college students, have always been at the forefront of major social movements. I mean, we've seen it in the Vietnam War and the civil rights movement of the 60s. I mean, even right now, Black Lives Matter, student activism has always, always, always forced society and the world to change, and always for the better. And so our youth units across the country are engaged at the local, the state, and the national level to bring attention to issues that include health, and how health does impact our communities and impact other communities of color. And so I think that it's really important as youth that we stay involved, because in 20 to 30 years, it's going to be us at the forefront of government. It's going to be us at the forefront in the medical field, in the political field, making decisions that are going to affect other people's lives. And so I think it's really important that we get involved from a young age. And even during these times, our members and our youth leaders are eager to do something to give back. And so, as we've brought these town hall conversations to college campuses and communities throughout all of the regions of the United States, we've worked with the Gift of Life to give everyone who participates a choice of simple actions that they can take to make a difference. Among some of those actions include joining the Gift of Life Marrow Registry so that more people of color can be matched with a life saving donor, definitely being proactive in caring for your mental health or helping a loved one who might be struggling to find the right mental health care provider, getting involved in things that impact your community and our world at large. One way to do so is joining the NAACP. And one thing I always like to mention when I talk about membership in the NAACP is that most people think that you have to be Black to join the NAACP, and you don't. The NAACP's mission is to advance African American equality and equity in the United States of America and around the world. But that doesn't mean you have to identify as Black. We're just helping to push Black people forward so that we can be a part of culture. And so please don't let that deter you. Or if you know people who might think that, hey, I really care about these issues, but I don't identify as Black, you don't have to be Black to join the NAACP. So please, I encourage your membership. And even if it's not the NAACP, look into Black Lives Matter, other organizations that are really doing this work to help highlight the struggles that are happening in the Black community. And then also, what I'd like to encourage is that if you're interested in medicine, or if you know other people who are interested in medicine, please, please encourage people to become medical care providers. According to the Association of the American Medical Colleges, only 5% of all healthcare providers or doctors identify as Black or African American. So if you know anyone who identifies as Black or African American and that they have a special interest in health, help encourage them to become a healthcare provider, because we need more Black doctors. And that way, definitely, if there's more Black doctors, it will be easier for Black patients to have that conversation about whether or not they feel donating is right for them.
Well, Maya, thank you. I would say I have to share this out loud to everyone who's listening. Kamaya is a very young 21-year-old, extremely smart beyond her years,
Thank
young
you.
lady. I'll also give a shout out to my daughter who's at UMass right now, and she's pre-med, so she is studying to be a doctor. So
Yes,
really,
that's amazing.
I know you're a. So with that said, let's bring all of our panelists back. Um, and as I mentioned to the audience, if you have any questions, we're going to start the Q&A. Please take a minute and put your questions in the chat. And we'll get started as soon as we get some questions. Shan, do we have any questions, or Greg, so far?
They're on the chat.
Perfect. I don't see anything coming in yet.
May I just make a comment while we're waiting?
Sure.
So support the idea of encouraging people of color to get into the mental health field. Again, you know, when you don't know your patient's culture, and you have to, you know, be humble about not knowing, there's limitations to that. We need a more diverse workforce in mental health. And I think it's really important to pursue that idea. So as with medicine, if a person really doesn't like organic chemistry, medical school may not be for them. There are many independent licenses that people can have a wonderful career being in service to people as a mental health counselor, social worker. There's a lot of areas that you can pursue, and organic chemistry does exclude a few people from service, but doesn't have to be the truth for all mental health.
It was not my strongest course, I will tell you.
I've heard that many
I'm
times.
still here.
You made it. You did it. So congratulations. My daughter is struggling through it as we speak. I've heard
She'll be
organic-
fine.
Thank you. All right, so we do have some
Battling.
coming in. Dr. Duckworth, where do we send someone looking for a therapist?
That's a great question. Let me just start by acknowledging the mental health field is fragmented, organized, poorly coordinated, and is basically a series of independent services that are not usually pulled together. If you find a service that is organized, stay with it. Whatever you do, don't fire those people, right? Because the average practitioner is working independently for themselves. They're not necessarily part of a large system. Now, Dana-Farber and related facilities do have mental health practitioners, but they typically don't have the capacity to see people in an ongoing way. If you've had a bone marrow transplant or you're going through, what is an extremely stressful situation, work with your doctors, find out who they recommend. There are some mental health practitioners who are actually interested in this collaborative model of working with people through this particular opportunity for life. I would say if you're not thinking about a bone marrow transplant, good places to start would be your primary care provider. They have come to realize that half of all primary care relates to mental health or substance use in some way. They won't be surprised. Like, they know this is part of their role, and they may have a knowledge of a clinician or a therapist that their office is connected to. Another thing which people don't know is to call your health plan. Your health plan at Blue Cross Blue Shield of Massachusetts, there's 15,000 independently licensed mental health practitioners. We can't make sure that one of them will see you because, again, they're independently functioning entities, but we will worry with you. We will make phone calls with you. We will problem solve with you. And I think it's really important to never worry alone during difficult times. And when you need a therapist, actually, it's a good time to have somebody working beside you.
Hopefully not too many of the listeners are planning on having a bone marrow transplant, but if they do, we do have mental health professionals, we have psychiatrists and psychiatric social workers and such that are part of our program that work with us to maintain the
for a very specialized need, right? And so they're part of your team.
That's right.
Right. But I could imagine a person post-transplant and having mental health problems years down the road, or if you don't need one.
That's absolutely true.
I think it's also worth mentioning at this juncture the relevance of telehealth for behavioral health. We saw an astronomical spike in our claims for behavioral health being provided through telemedicine during COVID. And we believe it's a twofold issue. One, certain behavioral health conditions were unearthed, but two, the accessibility and applicability of therapy via telehealth is like no other in any other medical specialty. And it is almost made for telemedicine. So we have entered a new phase of using video visits, and behavioral health access through that means has really opened it up to many, many more people.
One other point to that, the mental health field was reluctant to do teletherapy, telemental health visits. It's basically a back road no one used. Now it's a 16-lane highway because it's the only way to see patients safely. What people have learned is for the vast majority of people, not everyone, this is safe and effective. It's easy to use, and the no-show rate is 0, which is a big risk in the mental health field when you have a time that you've allotted and a person can't make it because of traffic or something. Also want to emphasize the importance of using the phone. Some people do not have access to the internet, and some people don't have privacy due to the small space that they live in. And so phone sessions, non-video, it's great to see everyone tonight, but when you want to talk to your therapist, if you don't have the internet, using an old school phone is going to be the best way. And we think that's a very important development from an equity point of view.
I also just wanted to mention and just highlight very quickly that I know you guys mentioned Blue Cross Blue Shield, but if there's anyone who's worried about mental health and finding a provider and worrying about the cost of it, mental health, I would love to emphasize, is not a luxury. Everybody deserves to see a mental health provider and talk about mental health. So if you're thinking like, oh, I don't have time for that, I don't have money, I urge you, even Mass Health, I used to work at Mass Health last year. If you call Mass Health and ask for a list of their providers, they can share with you what providers in the state of Massachusetts accept Mass Health. So it's not if you can afford it, yes or no. Like, definitely check with your insurance.
There is no health without mental health.
Are you finding with teletherapy that people are more likely, I know you just said that typically people show up for all their appointments, but I think you mentioned earlier that Black and brown communities are struggling with transportation and just the simple ways of getting to the doctors. So are you finding that you're starting to see more Black and brown patients as a result of teletherapy because it's easier for them to get around?
So this is the rub. We don't have adequate data to know precisely if the members accessing those services are disproportionately people of color or not. We have some of that data. It's imperfect and it's highly dependent on our members, those patients, supplying that information when they register. A lot of people don't reply, it's not required, or the choices that are there don't resonate with who they, how they identify. So that is a little bit of what I was getting at, speaking about how part of our commitment in this space is to find new ways to get that information, both from the individuals themselves through their registration apps with us, and explain why we want it, to be able to help them. Some people don't answer it because they don't trust how the information is going to be used. So full whammy. And we want to do as much as we can to get around that catch-22 because we need the information in order to answer the kinds of questions that you just raised. And if we can't answer the questions, we can't figure out what the best solutions are.
But isn't there also the problem that not everybody has Wi-Fi access or is capable of doing telehealth? Or
it is, except during COVID, at least, a lot of those regulations were lessened as far as what Ken alluded to too. Just an actual telephone visit can be held now. And we all have to figure out where we're going to land with telemedicine after all this hopefully calms down. But we're not going to go back to where we were 100%. And I think there will be more accessibility by a purely telephonic method, especially for behavioral health, than for sort of physical medicine visits by video.
No, that's great. Let me switch gears. We're getting several questions coming in. Jay, can you just take a minute and explain to us how you join the registry? We've gotten several questions on that, so let me just ask it up front. I think it's important for people to know, and I think it's pretty simple.
Yes, yeah, you're right. It is actually very simple. It's really just a cheek swab, much like this one. And traditionally, in non-COVID times, we run thousands of donor drives every year on college campuses, at churches and synagogues, at community centers, in corporations. But naturally, because of COVID, we're not doing as many in-person donor drives. So the best way for people to get swabbed is by going on our website at giftoflife.org. Requesting one of these simple cheek swab kits. It's sent to them in the mail. You sit at home in your kitchen, you swab the inside of your cheek, you put it back in the envelope, send it off to the lab, you get tested, and as soon as those results come in, that's paired up with your contact information and your health information, and you get into the registry, and you stay in the registry until your 61st birthday. That being said, I think it's equally important to share with people that there's a lot of misinformation and misperception out there associated with what's really truly involved in being a bone marrow donor. I think a lot of people get that information from the movies and from TV shows, and that's unfortunately more often very inaccurate than accurate. Hollywood tends to over dramatize the process for entertainment value. The reality is that for about 80% of the donors who are called as a match and given the opportunity to save a life, they're donating stem cells from their blood in a very similar procedure as is used when donors donate platelets in a blood center. And the way that I like to explain it to people, at least here at Gift of Life's Collection Center, and I know that Dana Farber at the Kraft Blood Donor Center, they have a wonderful center as well. You go in the morning, you watch Netflix, you have some chocolate chip cookies, you enjoy some video games, read your iPad, and after a couple of hours, you're disconnected from the machine and you get to go home knowing that you've saved a life. And that procedure really just involves a needle in each arm where we're taking blood out of one arm, taking out the stem cells through a machine that's basically a centrifuge, and putting the blood back in the other arm. So I mean, what easier way can one have than to save a life? And it's really the greatest gift that one person can give to another. About a week or two ago, we had former NBA player Walter Bond as our moderator for another town hall, and I really loved his advice. His advice was never be a spectator, always be a participant, have the right mindset, and be an impact player. And this is how you start being an impact player when you want to have the opportunity to give the gift of life to another person in need.
And it's so easy, right? I have to tell you, I didn't know much until I started watching the videos specifically about that piece. It is so easy for all of us to get involved. So thank you for sharing.
Yep.
Dr. Anton, can you take a minute and just explain how a sickle cell patient feels after their transplant?
Absolutely. That is one of, I've been doing transplantation since 1984 or so. The bulk of my career has been treating people with leukemia and myelodysplastic syndrome. I don't want to say that that's not fulfilling. It absolutely is. But if you take somebody who's 50 or 60 years old, who's been sick for a few weeks or a few months, and then do a transplant, it's spectacular. But if you compare that to a 30-year-old or a 25-year-old person who has had pain almost every day for their entire life, and in fact, often doesn't know what it feels like to have no pain, to be able to do this procedure and have the pain go away is astounding. These are I got to say, they're the most grateful, the happiest people that you can imagine. Some of them have no conception of what it's like to live day to day without pain. And after the transplantation, they get to experience that. And it's just a wonderful thing for me and for them.
I would imagine. Kamaya, one listener wants to know when you're going to run for political office. I thought I would share. I might be wondering the same thing.
I will be running for president of the United States in 2044. So
you have my vote.
I appreciate that.
Dr. Dallo, can you take a moment to share your involvement with the patient looking for a match? What does that look like?
So, despite all my years in medicine, I really didn't have a lot of experience as far as patients of my own with bone marrow transplantation. So certainly treated many people with cancers, but and just 3 years ago, I have young children and a dear friend, neighboring family. They're 15-month-olds, youngest of 4, developed aplastic anemia and a very, very rare version of it. Her mother's in healthcare, was desperate to figure out, what to do. She underwent treatment. The only thing that was going to work is a bone marrow transplant. This is a Caucasian heavily Irish Anglo-Saxon little girl who they could not find a match for. So here we are talking about inequities for people. And as Jay mentioned earlier, matches are not a dime a dozen no matter what your heritage. So it's even that much more important when you're talking about people that are underrepresented in the registry to begin with. Our community, our town rallied around this family and this little girl. She was on the news. Her parents went to all lengths to make just the concept of bone marrow registration and the importance known. And I admire them to this day and will always. Luckily, Ellie did receive her transplant. And I believe she's 2 years post-transplant now. She's, thriving. She has issues, obviously, from all those, all of her treatments, chemo, radiation, and the bone marrow itself, but she is doing fantastic. The whole family is sort of back to their usual activities, although COVID took a little turn. But one of my favorite stories about Ellie that's particularly germane to this conversation is a story her mom told, I believe in a Globe story, about how Ellie looked at her team. And she had vast majority of her treating providers were white. And this gets to the statement that was made before about Kamaya, about having people of color in the actual treating positions and being able to establish those trusted relationships. Ellie, to this day, believes that the custodian who every day swabbed the floor and the hallways of the transplant unit at Dana-Farber and Children's Hospital, she called him Mr. Lucillo. Lucillo was his name, a Black Hispanic gentleman who would play hide and seek with her through the window of her isolation room every single day. And when she went back in for follow-up visits, all she wanted to do was see Dr. Lucillo. And that speaks volumes to me. And she's doing well, but I think for this town hall, that story, what if Lucillo really were Dr. Lucillo? And that is something that, for her it is, but we all know the reality.
It's true teamwork. That's what it sounds like, true teamwork all around. Thank you for sharing. This next question is for the entire panel. For people of color, underrepresented, specifically Black and brown people, what words do you use when you feel misunderstood by your provider? Now, we know this is prevalent. We hear research suggests this often, right? What are some of the tips that you can share for those folks listening today? How should they handle these situations when they don't feel like they're being heard?
The first thing that occurs to me is to say, stop us. Just have the courage, if you can, to stop the provider, the person you're interacting with in their tracks, because even if you do feel heard, we know, especially with difficult news, things like cancer or other potentially life-threatening situations, once people hear that they only hear 20% of the conversation from that point on, and it needs to be repeated. If they already feel like they're not being heard, you're going to be lucky if they hear 5%. So to have the courage to be able to say, stop, please explain that to me again, or this doesn't make sense because we won't get better without that.
Yeah, I absolutely agree with that. As somebody who does a very technical type of medicine, I have to be very cautious about not slipping into jargon and adhering to sort of my agenda as opposed to the patient's agenda. And I think as Dr. Darrow points out, I think you need to step up and say, whoa, let's stop here and reset and in such a way that I can understand it better.
I have a colleague at the National Alliance on Mental Illness, Christine Crawford. She's African-American. She and I were discussing how I wasn't trained. I shared that I wasn't trained to talk about race in the clinical encounter. And she said, Ken, neither have I. And she's in her early 30s. So, you know, she's a good deal younger than I am. And Christine's advice, which I've taken to heart, is to just be able to say, can we talk about the fact that, you know, I may not have a good understanding of your culture? And then just listen and see what a person says. Or what is your experience of this culturally? Because I need to learn more. And Christine would say she wasn't taught to do that either. And it's just interesting to me. She's such a leader. She's brilliant. She's a medical student educator at BU. She's a superstar. And it's interesting to me, she is going to help move this equation forward. But I was impressed that she wasn't trained to think this way. And she's inspiring to me.
Let me ask each of you this question as well. This year has been a crazy year across the board in so many ways for everyone, right? Black, white, Hispanic, everyone, Republicans, Democrats, across the board. What are your hopes for 2021 in this space? I'd love to start with Jay, and then I'll move over to Dr. Anton, Dr. Dallow, Dr. Duckworth.
I am muted. Sorry about that. I'm hoping that as we enter the new year and as hopefully we get past the pandemic, that people will realize after being through so much trial and tribulation, the things that they have to be thankful for in life, and the things that they can do to help other people who are not as fortunate. You know, and that's one of the reasons why I got involved in this after my own transplant, was really just to pay it forward for the gift that was given to me and help other people in similar circumstances. And I'm hoping that people will come through this pandemic, you know, for those who can count their blessings, but then pay it forward and help all of those others out there. And, you know, certainly from what we do with marrow and stem cell transplants, you know, no patient ever wants to be told that a cure exists to save their life, but they don't have an equal opportunity to receive it because of their background. So, you know, as Walter Bond said, don't be a spectator, you know, get involved, be a participant, and help people in need.
That's
So
great.
let me answer with an anecdote. I was in Brooklyn on Saturday, and I'd taken my granddaughter to Fort Greene Park. Uh, and we were about to go to lunch, outdoor lunch, of course. And around 11:26 or something of that nature, when CNN announced the winner of the election, every horn, every car, automobile horn, every person standing in the street, it was like clockwork. It was amazing. The cheering, the beeping of the horns, the pounding of the pots, and this went on continuously for hours. This was a very uplifting experience for me, who had been somewhat despondent about our political situation. But where it applies to medicine is that I think that this level of enthusiasm and understanding of that we may be in for a political change that will allow us to address not only medical issues but social issues and how they're interconnected. I'm really looking forward for a very significant change in attitude, I guess, that will translate into a change in outcomes over the course of the next year.
All right, I'll go. I agree with everything that others have said. I will even take it one step further with the, there's a buoyancy right now, I think, around COVID and the prayer that we might handle this better as a nation over the next year or so. I don't think it's going to be quick. where what I really would like gets back to something that Jay said about thinking about others. And in particular, I'll use the specific example of COVID vaccination. It will have to be very deliberately allocated. And this is not I know I'm getting very specific, but I really hope that in 2021, we as a nation can start to look around and realize I may not be first in line, and that's okay. And the reason I bring that up here is that it's going to be people that are immunosuppressed, that have cancers, that have other diseases who should be first in line, and certain populations that are communities of color who may not be in that category, but have other reasons based on socioeconomic factors, living conditions, other things. And we all need to link arms and understand that this is bigger than any individual one of us. And that's the only way we're going to save all of us.
Dr. Duckworth, and then Kamaya.
Well, I'll start with things that have nothing to do with behavioral health. You know, I'd like a government that looks like America, and we've already made a step. And I think that's one step. I'd like a vaccine because people need to connect to each other. This video thing is fabulous, and it's really nice to meet you all. I like hanging with my people, hugging them. What my hope for 21 is that as 42% of Americans reported clinically significant mental health symptoms, just about half of people, and it's not over in terms of other people will experience grief, job loss, like there's going to be hits ongoing. My hope is that we remember what it's like to suffer with a mental health condition so that people who live with these conditions don't become the other. There's nothing more human than anxiety, depression, post-traumatic response. Bipolar disorder is a disorder of the brain. There happens to be a neck that connects the brain and the body. My hope is that what we've learned from our respective experiences of isolation, anxiety, depression, loss, we hang on to that. Once there is a vaccine and once there is a competent response to the pandemic, that we don't forget that mental health is part of health, as my friend said earlier.
Kamaya.
Yeah, I think that going into 2021, I'll quote Congresswoman Ayanna Pressley. A lot of people asked her, what are your plans into figuring out a new normal? How do we get to a new normal? Or how do we get things back to normal? And one of the brilliant things that she said is that I don't want to go back to normal, because normal for me and normal for people who look like me is not okay. Normal for you is not how we should exist, in this society. There's nothing normal about criminal injustice. There's nothing normal about health disparities, and there's nothing normal about job loss and being afraid to walk down the street and being targeted. There's nothing normal or average about that. And so one of my things that going into 2021 is that not only do we look at the pandemic, but we also look at the pandemics that were happening before COVID-19, and addressing issues that were already happening within the Black community and other affected communities of color, and really getting to the bottom of how do we fix these systems that have clearly been broken and operating broken for a very, very long time. So that's one of the things that I hope to see next year.
Thank you. Let me just take a moment. We are at the top of the hour. That was a fast 60 minutes. I want to take a moment and thank each and every one of you for spending an hour with us. All of you, I appreciate the panel. I've learned so much, and I'm sure the audience has learned a lot as well. Audience, we appreciate all of you and all the questions that have come in. Continue to learn and educate yourself on this topic. Jay is a perfect example of what can be done. So knowledge is power. Continue to educate yourself. Thank you all and have a good night.
Thank you.